There's just so much in that presentation that is ripe for discussion. It certainly responds very squarely to where Victor left us yesterday, and thinking about how the grassroots efforts on the ground, faced with incredible need, are coming up with a whole host of innovations that are starting to become sustainable. And just having that presentation alone just reminds us about the importance of listening to what's truly happening on the ground, and seeing how we can lift up those ideas and models. So I'll open up the floor for any specific questions for Mirai, and then we can have a broader discussion as well. Marty.
I just want to share, in February I visited a branch of SEWA that I hadn't visited since the mid-'80s. And it's an example, a model of low-tech and decentralized, which was a local, in a sort of slum colony, local information center. There was a women's group, and the leader in her own home ran an information center for other women. And she had on file all of the forms that you had to fill for all the different schemes and entitlements that they would have. And at the information center, they would help the women fill the forms and let them know what documents they had. Now you think of that, that saves probably 3 trips to that office, and addresses some of the very important concern that Peter mentioned, or somebody, no, you, Barry, mentioned about having to spend a day, an opportunity cost. It's low tech, it works, and it was very exciting to see. Thanks to SEWA.
Any other questions? Yes, Elaine.
So thank you. That was really very interesting. And I would just make one point, that you gave a terrific example of one of the things we talked about yesterday in terms of making a market. So really the low-cost drugs, and you could argue obviously also medical devices, you've got a guaranteed market right there. And so I think that's a very meaningful place to really examine the private sector partnerships.
Yes, please, Michael.
One of the challenges, first off, congratulations on those presentations. They were riveting. I have copious notes here that I'll digest later on. One of the challenges, I think, in looking at informal communities, informal workers, is where do we need to set up systems that respond just to their informality? And where do we tie into the existing formal health systems? I think that all of us would agree that our bias is not to recreate the formal national health systems, but rather to find creative ways of tapping into them. But could you speak a little bit about your experiences and maybe even some guidance and principles as different countries are looking at this challenge of how to connect informal people with formal health systems?
Great question. It'd be great to hear it from each country context if possible. Somsak, do you have some points to add?
Thank you, Michael, for that question, because I have made notes of that as well, listening to Mirai presentation and also to Barry reflection on the South African cases. Let me start by what I think is the reality in Thailand. Despite the fact that we have the universal health coverage, I think there's still a gap of health needs from the informal sector workers' point of view, which is the preventive part. The health risk management part is still very much missing, partly because the existing health system has not been familiar with that. In other words, we haven't had that experiences, we haven't had that thinking, that programs. In a Thai context, if there had been more concern, there could be a program maybe 20 years back in our 5-year plan. And then we might have had the capability to deal with that. And then with the universal health coverage, it will be automatically integrated. That has not been the case. So I presume, as I say, there are always new challenges facing any health systems, whether it's a UC finance or it's not a UC finance thing. So to me, that would be one of the very important things to keep in mind. And even though we have the UC, that's another issue. We still have to find a way to integrate it within the existing financing model. In other words, we have to find the purchasing methods to make sure that the existing financial systems find its way to attract or to motivate both the supply side and the demand side to make sure that the money would be cost effective. But that to me would be a reflection of the Thai system. But let me go to a more general kind of things. Listening to Mirai presentation, I think there are at least 3 dimensions that are interrelated. One is what you could call a service package or benefit package or service provisions or interventions, which is basically what I would call curative and risk management kind of things. The second would be the financing part, which again could be a so-called general financing systems, such as the UC, the Thai context, or insurance-based. It could be HMO, it could be existing, indemnity-based insurance. I'll come to that a little bit if I have the time. But the third dimension would be the service providers or the system, which there are again two dimensions. One is the so-called the entry point, the system entry point. And it was very clear that district health systems or primary care would be a very important thing. But the other part would be the capability. So if you put all these 3 dimensions together, you started to see where the system gap would be. Again, I use my Thai system. If I analyze this based on this framework, I would say that, yes, we still have the gap that would need to reorient or build up the system to address the preventive part. Whether we address that to the general UC, we create a separated so-called financing thing. It has been very obvious to me that we won't be creating a new cooperatives, especially for the informal workers. In terms of the system, again, the district health system would be a very good entry point. But it always comes back to us, how much we could add on to the district health system workers. To me, the answer is very simple. Whatever is needed. In other words, you can do 2 things. You can always do 2 things. One is reorientation and redeployment. And as I say, health system need to look back at ourselves, whether we are addressing the kind of things that we need to be addressing or not, or we need to reorient our health personnel. And I mentioned a little bit about elderly, chronic diseases, informal health workers, health would be another thing. But the capability part would be something that I would say not too difficult to address. But the entry point to me would be very crucial. So that would be the so-called the 3 dimensions of the system analysis that I think would be useful to think through.
Great, that's very helpful to outline. Barry from South Africa.
Yeah, so as I pointed out that I think one of the first issues is it's only 5 to 10% of workers in the formal economy in low and middle income countries that actually have occupational services. So let's not forget that when we're developing an occupational system, Ivan's got the data. So in the north, I don't know about the United States, but in Europe, occupational health is now, mental health in the workplace is the issue they talk about in Europe, mental health. In our countries, we're still talking about hands that get lost, people that die, people that have severe chemical exposures, etc., pesticides and crop spraying. So you're really looking at 2-dimensional issue of the north having covered occupational health, where it's taken for granted that you will have a safe and healthy workplace in Switzerland, in Sweden, in Norway, etc. So the countries of low and middle income countries, firstly, we don't have a health system that covers workers in general. So for South Africa, as we're building the health system that covers all workers, 17 million workers, we are incorporating elements that will cover informal sector workers. And that's a discussion we need to have with colleagues that work with informal workers, because it's a very particular space in terms of how you reach out, etc., etc. Now, what we are looking at the model in the policy reforms is firstly, what are called one-stop service centers. So in the primary healthcare, to have designated places where workers don't have to go through queues. So they would come to a primary healthcare center, but workers might actually bypass a queue by going to a workers' health center. So they shorten the queues. So the kind of issue is to discuss how do we put up these one-stop service centers as we can actually, next to primary healthcare facilities, district hospitals we're talking about, but to actually have some model that goes to it. The other issue was some elements of social protection. If workers actually know there's elements of social protection, then like compensation. So I'm not saying that there's the moral hazard problem, that you cut your hand in order to get a disability grant. But the key area was the key area around how do they access social protection instruments in the event of getting ill. And that means talking to another government department, the Department of Labor, about extension of social protection mechanisms that cover this and how we finance that. Because this is an enabling tool that we are saying that as you have this wider social protection instrument like disability grants, unemployment insurance fund, etc. How do you extend that? And for South Africa as a upper middle income country, we think we can do that. It might not be possible in other countries which are low income and lower middle income, but definitely for an upper middle income country like South Africa, it is possible to extend these policy instruments. So that's the issue, and then you actually have the issue around the services. On the service delivery, the prevention aspects are very important. So the Thai home-based care workers, personal protection, gloves, trying to work through enabling mechanisms, for recyclers, working with gloves as personal protection becomes an important instrument for them. Now, who funds that? So firstly, to make some good quality gloves, and then to fund them and to actually provide that. The point you made about the carts and some low instruments. So I think those are the issues that we are discussing right now, is the prevention aspects as well as the service delivery aspects that we can actually put together. Now, the last issue on the public-private sector. So the discussion we had on Monday, which is why I only landed up last night coming to this meeting, was we are introducing what's called the certificate of need in South Africa. So we've had a parallel system of 20% of the population is covered by private healthcare, the health funds, as we call them, medical health funds. So it's 20% of the population, and the 80% is covered by government. Our new policy reform is universal health insurance. So we'll have one health fund. I'm not too sure what's going to happen with the other 150 health funds that we have, but there is one health fund that's coming into being over the next 15 years in the country, kicking in last year in some of the pilot demonstration sites. Now, part of the process, we're introducing a parallel process that you cannot open a private hospital or a private clinic or a private radiology center without what's called a certificate of need. And it can only be given by the federal government, not by the local government, because there are problems around corruption and a range of other issues. So the federal government will say that if you want to open up a new private hospital in Washington, then there are certain requirements you have to meet, because you might have to deal with some rural parts of Georgia or North Dakota, where maybe we need a private facility in North Dakota. So maybe we'll give you a certificate of need to go and set up a private radiology unit in North Dakota, as opposed to additional 10 units that are coming in Washington. So there's the issue around that. That was the discussion that we had with the private sector on Monday, which said, we will give you a new certificate of licensing, but can you help us with the small and medium enterprises? Because you've got a large concern for this Toyota plant. Down the road from you is the auto supply components industry that are small and medium enterprises. How will you provide services to those small and medium and micro enterprises? And how will you provide services for the informal economy? So if you can give us that justification of lowering the burden of disease, because you've got technical expertise in the large enterprise called Toyota or Anglo-American Corporation. You've got the doctors that work in occupational health. You've got the nurses that work in occupational health. You've got the occupational hygienists. How are you going to extend your services to the vulnerable and the poor? And in terms of that, we will give you a certificate. So that's the discussion we had on Monday. So what I'm getting at is there are policy instruments we can start playing around with. That means that the private sector survives, but at the same time we get some returns that helps out some other neighborhood in the terms of the technical expertise and inputs. So I'm glad that I could stay on Monday with my minister and discuss this with the captains of industry, and I hope I didn't miss out too much yesterday. Thanks, Marty, for your input. But anyway, those are some of the discussions we're having right now in South Africa in terms of service delivery, about models for service delivery, prevention and interventive. Universal health financing will take care of the issues around the financing models, including occupational health. But we have to work out what will be the models for social protection, because that's a slightly different issue. So universal BS, at the end of the day, at the point of entry into the system, nobody has to pay. That's what ultimately universal health financing will do. We just have to improve the service delivery, and we're working with policy instruments on service delivery.
Great. Thank you, Barry. We've got a few questions. Let's finish off with Marty to get a sense of what's happening in India. And then if folks from the back want to come closer to a microphone, then we can start taking questions there as well.
I think I understood from Mike that the question was on how to connect informal workers with the formal system, both public and private. So I was just noting a couple of things that we have done and which we found work and are quite workable, but you have to have a dose of patience and persistence. The first is training a team of frontline workers, which I've been on about since yesterday, and their own organizations. I think it's very hard for both public and private providers and institutions to deal with an amorphous mass of informal workers. They like to deal with an organization which has a name and a face, which has some credibility, and which importantly has grassroots reach, which they don't have. The second thing that we've done a lot, and we borrowed this idea from our friends from Thailand, is to have health assemblies. So we get a sense of what are the needs of local people, informal workers, what are their priorities, and we invite public and private providers to these sessions. Again, for them, many times they say it was a revelation, they had no idea, and so on. The third thing we do regularly and carefully, systematically, is to build up a network and a relationship and interaction with primary healthcare doctors and nurses in our immediate neighborhood, in the catchment area where the informal workers live and work. So we become friends with them, if I may put it that way, and we help them in their work. Part of their work is to go around doing checkups, making sure all the kids are immunized and so on. And we help them by mobilizing communities, by informing people, by reminding people of the date and so on. So I think when you're helpful to people, they also, as we know, respond. And then we're able to get some ideas also across to them. Often the government and private providers would like to set up diagnostic and screening camps. They don't know how, they don't have the outreach. So that's where we come in handy, and we organize those for them as well. The other thing we do in our system, it goes right down to the village level. We have state, then we have district, then we have the sub-district level, which we call block. Each block has a health officer. We regularly interact with our block health officer. That's the first person we are in touch with. Anything, if we suspect an outbreak of leptospirosis, or we find a family where there is a child who seems to have anemia and maybe a sickle cell anemia case and so on, we bring it immediately to the attention of the block health officers. So that is an interaction which is very valuable and that we carefully nurture. And also every quarter we meet with the district health officer, or in the urban areas with the municipal health officer. So it's really about building these kind of very close kind of partnerships. I think one thing that they really appreciate is that we transparently share whatever data in our reports that we collect from the ground. And I mentioned in passing yesterday, one of the problems of both the private, but particularly the public health system, is that they don't get authentic data. They don't have an idea of what's going on the ground, because the way the system is set up, there's a built-in, disincentive for people to report accurately back. The other thing that we have done, which is helpful in making this connection, this link, is actually helping them implement their own program. So for example, they approached us, the municipality, and said, in such and such a ward of Ahmedabad city, will you take care of the TB control program? We'll give you the resources and we'll help you set up the TB lab and so on, but you do it. Or the pharmacies. The pharmacies were set up initially with the grant of 500,000 rupees from the Ahmedabad Municipal Corporation. Of course, they asked for it back later. They said, sorry, it was a no-cost loan. So we said, okay, have your money back, because we had already made the money. Then the other thing we've helped them with is village health, sanitation, and nutrition committees. These health committees I was talking to you about. They have a small budget. We found that the budget was being used by nurses and doctors for buying new curtains, doing whitewashing, buying furniture. Not meant for that. They have separate budgets for that. So we started working with these local health committees, and now urban committees as well, to get them active, so that instead of one frontline worker interacting with the health system, now you have a committee, a team, and a lot of the health programs and all can be done with the help of the team. And the last thing that we did to make this connection is to build up networks with private providers for things like mobile clinics. Some people mentioned yesterday that informal workers, quite true, don't have the time to stand in long lines or go according to the hours 9 to 5, because their lives are not 9 to 5. They're 24/7. So, mobile clinics according to their hours of convenience and work for informal workers. And here the private providers, I must say, have led the charge on non-communicable diseases, which is something you brought up. Unfortunately, we are the diabetes capital of the world, we are told. And there are a lot of private providers who actually set up these mobile clinics to do early detection and screening. And having seen this model work, then the government said, hello, why don't we do some of this? We have budgets for this. So these are the kinds of things that we do to connect with the formal system, both public and private.
Thank you, Mary. That was wonderful. So let's start with Marty, and then we've got a couple more questions. I'm being mindful of time. We have about 15 minutes left for some robust discussion. So.
I just wanted to pick up on something that Somsak's presentation has made so important, which is that the UHC is not a cube, it's a Rubik's Cube, because the system is the really key. And we've talked about which services and how financing and which population, but it's really the health system, and I think that attention is really important.
Thank you. Please.
Thank you very much. It's moving somewhat away from this part of the conversation, and I just want to say, using Barry's example of the Toyota, the huge Toyota firm in Durban, to introduce the 2 points I want to make. The informal economy is not outside of that factory. The informal economy, the informal workers are right inside there, in that corner over there, working for themselves, making the valves to put into the engines, mostly on their own account. But when Toyota, when a new huge order comes in, they are pulled in under contract for the next 3 weeks to do that order for export to Brazil. It's incredibly complex like that. And the conceptual point I'm wanting to make is to say, as much as we need to draw that line and say, this is informal, and to have those definitions, there's a very messy in-between place there which actually throws up opportunities for intervention. It might not be for intervention at the poorest end of informal workers. And two things that I want to just raise here, and I won't go on for long. One is, okay, Marty owns a shoe factory. Well, she doesn't know if she owns it, but anyway, she runs it and she gets the profits. And Ivan, and in the shoe factory, the bottom of it is made, but then the top is made by home-based workers in their homes, and Ivan's the runner. Ivan brings me the pieces. He brings me 800 pieces a day and comes back to fetch them the next day. I'm definitely working for Marty. There's no doubt about it. Okay, we'll discuss wage rates later, darling. Is there a possibility, and I'm thinking narrowly now, of responsibility of Marty for insurance for the people who actually are producing for her, no doubt about it, of extending accident-related insurance to my home, but that part of my home which is used for work? So I'm not saying just insure me if my whole house burns down because of some carelessness, but if I stick a needle through my finger in stitching the shoe top tonight, can Marty's insurance extend to my workplace? And it should be a relative. Everyone's going to, I know the first thing people say, oh, moral hazard or something like that. But there's a certain sense in which Ivan is Marty's protector there, because he comes, he knows what the house is like. It's like saying it's very unpopular to say this, but he's the kind of community runner. He's the runner between them. And he knows his butter is definitely on the side that's face up to Marty, not to me in this case. So let's think differently about the workplace, about flexibility of the workplace and what private insurance could cover. Not necessarily social insurance at all, but private insurance. And the second other consideration is thinking now, the other person the agency who comes to my house, my home, in my very poor settlement, is in fact the local municipality. I have some interactions with them over some things. The local authority has a budget in my city, in Durban, with Standard Bank, as it happens, of billions. I think it's 14 billion rand this last year. Is there scope in there for rather than saying we will set up self-help cooperatives or community-based, not instead of always, but where those are difficult to set up, as they are in South Africa because of its own political history, in fact, is to think of the local authority allowing access to the private bank for insurance, because they are they're in a sense the collateral. And we can negotiate around the conditions under which what kinds of insurance I can have
because I am, yeah, through the local authority. I'm stumbling a bit because I haven't thought it through, but we're wanting agencies of scale who themselves have an interest in negotiating with citizens, informal workers at ground level. And it's hard to do. It's hard to do at the kind of scale that SEVA has done it.
It's a very interesting idea. Let's get one more question in and then maybe have a bit of discussion about the reality of that. Peter, thanks. Let me move to, I'm sorry, it's because of the podium here as well. Please continue, and then we'll move to Peter. Go ahead.
I just wanted to bring one more point, and especially it was coming out in context of Barry's presentation. Even though we may get, like, we've been thinking about informal sector workers, but what about those workers who were informal sector? Even if we do something for them, once they are, say, out of work and they're old, they got their diseases when they were actually working. What about them? And I know it's a huge problem in South Africa with the mine workers. So that is another kind of a area that we would need to think about.
Very true. Peter, please.
So I'd just like to pose a question to the panel and to everybody to think about. I don't know whether this is too kind of linear thinking, but I'm a little bit confused about how we're thinking about this link between UHC and informal sector workers. In some ways, UHC is intended to cover the healthcare needs of everyone, including informal sector workers. So the lady who sticks the needle through her finger making something at home is no different for UHC than the grandmother, her grandmother, who sticks her needle through her finger mending somebody's pants. Okay, they both are entitled under the concept of UHC to get health care for that need. Now, I know, of course, that doesn't work very well, and there are lots of reasons to do special things and to meet those needs. But that's different to me than occupation-related hazards, which are things for which there's an argument for a special intervention. So the question I want to pose is this something we should be thinking about more carefully? Because in some ways, UHC and the things around it were created in order to avoid having to make employers responsible for those kind of injuries, right? They were created as an alternative, right? A way to socialize those risks and cover those risks more socially. At the same time, we know that doesn't work very well, and there's a lot of good reason to intervene, especially in the short run in countries where these things don't function very well. But it seems to me that that's a different question from social interventions to address safety in the workplace and occupational hazards and this kind of thing. And we seem to be blending all these things together. So I just want to put that out there as a question. And I am very conscious that, and especially knowing, the work that groups like Mirage does, if they were waiting around for Indian government to solve all these problems, they'd still be waiting, and I've known her for 40 years. So, so that's much to be praised. But at the same time, I hear Somsak telling us that UHC in Thailand has created a growing burden on the public health system, which they're having trouble meeting, which is a good thing because that reflects they're meeting these needs. But then do we want to add a lot of special things on top of that when the system is actually there to meet these needs? So at some risk of raising this uncomfortable issue, I wanted to just put it out there.
No, it's great, actually, and so it's definitely something needed of discussion. Somsak, you've got some thoughts on this.
Thanks, Peter, for raising that question. In fact, I plan to start my presentation by saying that the Thai UHC could be an interesting starting point to think about what UHC could do for informal workers, because it's exactly the issue that Peter mentioned. When we started UHC, basically, from an informal worker point of view, everybody is covered by the UHC because the so-called social security system in Thailand has not been able to cover the informal sector very well. I had a slide to show that only about 1.7% of the informal worker is now enrolled with the so-called social security system. But even with that, they skip the health benefit. The normal formal worker is covered with their health benefit within the social security system. But if you are enrolled as an informal worker, you are not covered because they are concerned about the so-called health needs of the informal workers, and it's voluntary, so they were afraid about selection bias. So they leave it to the existing universal health coverage system to take care of their general health needs. As I mentioned, having said that, it is very clear that if you compare to the formal sector workers, the so-called workplace health risk management part is missing. Whether we put this so-called workplace or work-related health risk into the benefit package or not, that's definitely one of the challenge for the Thai health universal health coverage. But again, I have to repeat that in this context, the Thai health UC system is quite generous in the sense that it's based on exclusion list, as I mentioned. Everything will be included. So it's always a constant challenge as to what would be added. And that's why we have to think about the so-called added benefit package. But we were fortunate to have. But I think Peter's point is very relevant. To me, I would wish that all countries using the universal coverage, the UC policy, as a starting point to better take care of the informal workers. When I listen to Mirai, the informal worker having to face tuberculosis, for example, it's very easy. We don't have a specific program for TB for informal workers. It's integrated already in the UC system because everybody who has TB has to be taken care of. And the TB, again, come back to Marty's point, the health system in Thailand know how to deal with TB, no matter what working status you are. So the health system capability is also something very important. And I like to emphasize the fact that it is a district health system. But let me continue a little bit more on the private sector because, I like to say two things when I listen to Mirai. On the insurance thing, I certainly hope that any countries who are not yet reaching universal health coverage or might like to think about specific insurance for workers, it would be good not to deal with what I would call indemnity-based insurance, but to deal with insurance that is more health maintenance kind of things. In other words, you insure because you wanted to make sure that there are services available, not because you want to reduce the financial burden, because that would be a big burden still for the workers. And we need to build up new private sector for that, if you would like to that. And social enterprise might be one of the very important approach to try to build up. I don't know how the insurance industry is like. On the provider side, I think also that even though we have the money and if we are looking forward to private sector providers, we also need new kinds of private providers. Thailand is a good example. We haven't not yet been very successful in having private providers, even though we pay for private sectors. Primary care providers in the private sector is still very much, reactive to the curative needs. They don't think about health needs of their so-called enrolled population. They don't do proactive. But the public sector could be in a better job, but they still also need some kind of a motivation and financing. But I'll stop there. Thank you.
Thank you. One last comment, Barry, and then we've got a couple more questions before we wrap.
I think we run out of time. So there's two issues. Firstly, the universal health coverage in our case is the service delivery package. And that's premised on a functioning health system, public or private. There are problems with functioning and dysfunctional health systems, but it's premised on the delivery of services. And within that delivery of services, there's a package of interventions, whether it's for workers, women, children, pensioners, etc. But that's the kind of stuff. The whole issue of introducing national health insurance gives us a financing mechanism. And that's the same. Other countries have got health plans, there's gap cover, and what's the exchanges that the Obama administration has put into place. So there are different ways people finance. In our case, we are looking at a model of national health insurance. We have these other health plans at the moment. We're not too sure what's going to happen to them, but ultimately there'll be a funded national health insurance scheme in the country over the next 15 years. That will be one financing mechanism for the health system. So that's the discussions we're having. The third component for workers is related to social protection interventions. And that's a discussion between the compensation issues. When you get injured at work, whether you're in the informal sector or the formal sector, you should have social protection. That's the belief that I come from, and I'm sure Francie shares that as the South Africans in the room, that we should be protected. Then there's the issue around unemployment insurance fund. What does it mean for us, and what does it mean in terms of pensions? There's a bigger reform taking place by our national treasury about the reforms of social protection in South Africa, and we are making those inputs. Now, the things that we can explore in South Africa as an upper middle income country would be slightly different from other countries north of us. So we can't impose a model north of us, but for South Africa, we definitely can work at some of these things that promote and protect the 17 million workers in the country and ultimately the 53 million. So the Brazilian model or the Thailand model or the Malaysian model are models that we could look at as middle income countries that we are beginning to work with. And what we are beginning to build in my presentation is a service delivery model alongside a financing model, and the third component being social protection. And that's what we need to explore in greater detail. We don't have all the answers, but we actually have the questions.
Thank you. Jennifer, you've got a question as well?
Excellent presentations and fascinating discussion. I understand it's important, I think, to continue the discussions about the linkages between all these pieces. But I also, in addition, think that the importance of the workplace, health risk assessment, the industrial hygiene, the hazard assessment at the workplace, that needs to be considered in any linkages. It's great to have the universal financing, the service delivery, but we don't want to remove from the employer the importance of that employer taking responsibility for the hazards in that workplace. So if it's easy to just send the worker with the back problem or the pesticide exposure, into the national health system, then you've removed some of that responsibility. Now, there's still, I'm sure, some very good linkages and ways to connect the two, but nonetheless, I think we need to remember that the employer and somehow the workplace, even the informal sector, there needs to be some responsibility for maintaining safety and assessing exposure and being responsive to what kinds of injuries and exposure toxicities are happening. They can't just escape into the national health system.
Very important point of caution as we're thinking about how to connect these things together. Marty, last point, and we need to move on.
I just want to get back to Peter's conceptual puzzle and why we put some kind of special emphasis on informal when it's universal general health coverage. And that gets back to the issue of the risks of exposure and the barriers to access. So we're really talking about the fact that both in their living and their work environment, the informal workers have greater exposure to the common health risks, the general health problems, right? And we're also saying that they have specific barriers to access that we need to think about, right? I think that's why the emphasis. And then we get to the occupational health and safety issue, which is who deals with the health outcomes of this unsafe environment and who's responsible for the safe working conditions. And your point is really important to keep in mind about the responsibility of the employers. And then there's Barry's thing that they also need pension and then they need a whole lot of other things that we haven't really addressed.
Well, thank you. Well, first of all, let's thank our panel. They've been really robust in keeping us moving with so many important ideas. One really important thing that we didn't really highlight, but I wanted to connect on, is each one of the panelists did raise an important partnership that was necessary in evolving the package that they're in, whether it be civil society and its role in Thailand and making sure that the services that are in the package are really meeting the needs of the community, the need for trade unions to now be part of the dialogue for informal workers in South Africa, a clear next step that needs to happen. And then, of course, Marty, with just a whole kaleidoscope of partners that have been coming up, including the formal insurance industry, which is just fascinating to see. And then, of course, the call to global employers to make sure that we keep them on task and making sure that we don't ignore the formal workplace that they're in. So I really appreciate the conversation that's happened here, and certainly we'll have more over the break. So thank you.